right, hello again. This is Jessica Taddeo, and this is video number 3 of 3 for my respiratory and cardiovascular submission. So I'm here with my patient. I'm going to go ahead and wash my hands, greet my patient. Okay, you put the sign down. Hello there, my name is Jessica. I'm going to be the nurse practitioner student taking care of you today. I'm going to be doing an examination of your respiratory and your cardiovascular systems. Okay, so I'm going to start with inspection. In order to inspect properly, I need to expose the skin. So sir, if you wouldn't mind, I'm going to have you take your shirt off. So I'm going to inspect the anterior and posterior chest, and what I'm looking at his respiratory rate, if he has deep respirations, shallow respirations, equal chest rise and fall. I'm looking at the skin for any lesions, any rashes, any noticeable masses, bumps, bruises, anything abnormal on the skin. Anteriorly and posteriorly, which I don't see. I'm gonna palpate next. I'm gonna palpate for any tenderness. If you just tell me if it hurts where I touch you here. No? Okay. And the posterior. Okay. Next I'm gonna palpate for tactile fremitus. I'm going to use this portion of my hand and feel in between the ribs, in the intercostal spaces, and when my hand touches you, you're going to say?
99.
99. All right. You ready?
99. 99. 99. 99. 99.
Perfect. So I should feel the vibration of his voice through the lung tissue. If I'm over bone, you don't really feel any vibration, but if you've got your hand over the lungs in the intercostal space, you do feel the vibration passing through. I'm going to have you turn around just so we can see your back. Yeah, I'm going to see your back on the camera.
Yes.
I know. Because I'm kind of doing the front and back at the same time, so I'm going to make you move a lot. So again, we're going to do the 99.
99. 99. 99. 99. 99. 99.
Okay, and again, tactile fremitus is symmetric bilaterally on the posterior lung surfaces. While I'm back here, I'm going to go ahead and check for chest expansion, and when I do that, I'm going to place my thumbs over the lower edge of the ribs, and then what I'm going to have you do, sir, is I'm going to have you take a big deep breath and out, and a big deep breath and out. All right, so you can see my thumbs move out and in symmetrically, so both lungs are expanding in an equal manner. After inspection and palpation is percussion. We're going to percuss over the lung fields. When we do percussion, I'm going to use my non-dominant hand, which for me is my left hand, and the middle finger, and I'm going to use the middle finger on my dominant hand, which is my right hand, and I'm going to percuss over the lung fields and just kind of tap, tap, and release. Kind of doing like a ladder-like movement across the back of the chest, so I kind of make sure I go over all the areas. And when you percuss over air-filled organs such as the lungs, it should be like a resonant sound, which I did hear. If you hear dullness when you percuss, it can indicate some consolidation over the lungs. I'm gonna have, let me have you turn around again so I can percuss your anterior lungs. So the same.
Let me help you with this here. All right, here we go.
All right, so the same thing in the front. We're gonna start. Okay, so percussion over the anterior lung fields is resonant bilaterally. So that's it for percussion. The next part is auscultation. So I'm going to listen to the lungs. So when I listen to the lungs, I'm going to listen over the upper airways, over the trachea. First, I'm listening for stridor or any upper airway obstruction. And I'm going to listen over all the lung fields, and I'm listening for wheezes, rhonchi, rales, any adventitious sounds that would indicate some abnormality going on in the lungs. So when you feel my stethoscope touch your chest, you're gonna just take a big deep breath in and out, okay?
Mm-hmm.
Alrighty. Wait, hold on. Actually, I want to start up here. Sorry. Alright, make sure she can see my stethoscope. Good. All right, so anteriorly, the lungs are clear bilaterally, no wheezes, rales, or rhonchi. I'm gonna do the same thing posteriorly in a minute, but let me do, while you're still facing forward, we're gonna do checks for egophony, bronchophony, and whispered pectoriliquy. All right, so when my stethoscope touches your chest, sir, we are going to have you say the sound E, okay? And then this is the egophony test. And so what I'm listening for is that it should sound like E and it shouldn't sound like A. So go ahead and say E.
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 And E.
E.
Okay, so I hear the sound of E every time I listen when he says the sound of E, so that's normal. I'm gonna do the test for bronchophony next, which is basically the same thing, except I'm gonna have you say
99.
Okay, so
99. 99. 99. 99. 99. 99. 99.
okay, so when he says 99, it's a muffled sound of 99, and that's normal. So no bronchophony anteriorly in his lungs. And the last one is the whispered pectoriliquy, and I'm going to have you whisper 1, 2, 3. And when he whispers, I should not hear anything through the stethoscope. There should be no vibration through the lungs when the lungs are clear. So, when my stethoscope touches your chest, please whisper 1, 2, 3.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Last one over here.
1, 2, 3.
Okay, good. So, and I do not hear any transmitted whispered sounds through the anterior lung fields, so that's a normal finding. So there is no whispered pectoriliquy anteriorly. So let's place the camera back over here and have my patient turn around so we can
Oh,
basically.
laying down now?
No, turn around, sitting up. So I can auscultate over the posterior lung fields. And so when my stethoscope touches your back, sir, I'm gonna have you. I'm gonna have you take a deep breath in and out through your mouth. Okay? So lungs are clear bilaterally. There's no wheezes, bronchi, or rales over the posterior lungs. We're going to do the tests again for egophony, bronchophony, and whispered pectoriloquy. So, sir, when my stethoscope touches your back, please say the E sound.
E. 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 E.
Okay, so when I auscultate over the posterior lung surfaces, I hear the sound of E as he speaks, and it shouldn't sound like A. It sounds like E, so that's a normal finding. The next is bronchophony, and I'm going to have you say 99 when I listen over your posterior lung fields.
What's the reason for saying 99? Why not another number? Is there a reason? Like,
Do you want to say another number?
no, I'm just asking.
I don't know, that's what the book says.
Oh, the book. Okay.
But I mean, it's just listening to the vibrations of your voice. I think when you make those like consonants, it makes.
Well, I wasn't sure if there was a scientific, like, is there like a sound that you're looking for, a 9 or whatever. But okay, if the book says it, let's do it. Let's go.
Let's go. All right.
99. 99. 99. 99. 99. 99. 99.
Okay, so posteriorly, there's no bronchophony present as, bless you, sir. I listened to his posterior lung fields. There are muffled sounds of 99, and that's normal. It shouldn't be clear. The muffledness of the voice transmitted through the air-filled lungs is normal. Last one is the whispered pectoriloquy, and I'm going to have you whisper 1, 2, 3 when I touch my stethoscope to your back. Okay?
Sure.
All right. Okay, so when he whispers 1, 2, 3, I do not hear any transmission of sound through his lungs, and that is a normal finding. So that concludes the respiratory examination, and let's move on to the cardiovascular examination. So for this part, sir, if you could lie down on your back, put your feet up, rest, take a break. Okay, and let me just reposition my camera here so we can see. Let's zoom in. Okay. See what's going on here. All right, there's my patient. Here's me. So for the cardiovascular examination, I'm going to start, as always, with inspection. I'm inspecting the chest. The skin of the chest just kind of goes with every body system as you examine it. You're checking the skin as well. So checking for lesions, lumps, bumps, bruises, anything like that on the skin. I'm also looking for any pulsations. Do I notice any pulsations over the aorta? Do I notice any jugular venous pulsations? Any pulsations in the sternal notch area? I'm looking for jugular venous distension. bilaterally. There's no jugular venous distension. I do notice the pulsations of his carotids and this way of his aorta as well. Kind of, if you look at it from the side, like with some tangential lighting, you can see it a little bit better. It's very faint. So after inspection is going to be palpate. I'm going to go ahead and palpate, let's just palpate everything. I'm going to palpate pulses first. I'm going to check temporal pulses. So temporal pulses are 2+ bilaterally. I'm going to turn your head, sir. I'm going to palpate the carotid pulse. I'm feeling for any like heaves or lifts in the carotids, and palpating the carotids one at a time. You don't want to compress both carotids at the same time unless you want to make your patient passive. All right, carotid pulses are 2+ bilaterally. Bring your arms up over your head since you're right here. I'm going to check radial pulses. It's probably unconventional position, but since I was here, we had one arm up here already. I'll check radial pulses, which are also 2+ bilaterally. I'm going to check brachial pulses in the arm. Just hold this arm up. Again, unconventional, but trying to show you on the video. And again, over here, palpating brachial pulse. Good. Let me palpate the femoral pulse. This is going to be in the groin. Oh, sorry. It's a little hard through the jeans, but sometimes you can feel it. Sorry. Put your legs straight. Okay. Femoral pulses are 2+ bilaterally. Maybe you could hold this, sir, and I'm gonna turn that around to your legs. I'm gonna palpate the. Let's see. No, not towards you. Turn this way, like to point at your legs. Okay, all right, good enough. I'm gonna palpate the popliteal pulses. Behind the knee. Posterior tibial pulses. See what I mean? And if he had his shoes off, which I should have made him take his shoes off before we started, to palpate the dorsalis pedal pulses.
And before I put my feet on the couch.
Yeah, right before you put your feet on the couch. So we'll just simulate that. So femoral, popliteal, posterior tibial, and dorsalis pedal pulses are 2+ bilaterally. So after palpation is going to be auscultation. I'm going to auscultate over the carotids. I'm going to listen with my diaphragm and my bell. I'm listening for any bruits, any turbulent blood flow, and I'm also just noting the rhythm. Sometimes you can hear a murmur over the carotids, so just kind of taking a good listen. I'm going to have you turn your head that way. I'm just going to listen. Good. So no bruits noted over the carotids. I'm gonna Next, I'm going to listen to his heart in a couple different positions and have him sit in a couple different ways as well, so we can get the best listen to all the heart areas. So the aortic is in the right second intercostal space. Actually, put your arms. It's hard to feel your ribs with your arms up like that. So second intercostal space on the right hand side. And along the sternal border. Okay. So, and then moving across the chest to the left second interspace. This is the pulmonic area. All right. Moving down the chest to like the lower left sternal border. Right here, this is the tricuspid area. And then to listen over the apex of the heart is going to be fifth intercostal space, mid-clavicular line. Alrighty. And while I'm here at the apex of the heart, I neglected to palpate for the point of maximum impulse, which should be in the same area, fifth intercostal space, mid-clavicular line. And there it is right there. So you can note the location, the diameter of the PMI. While he's still lying on his back, I'm just going to listen over the abdominal arteries, and then I'll have him turn and finish listening to his heart. So I'm going to listen over the aorta. I'm going to listen for bruits and any turbulent blood flow. And I don't think before I didn't really palpate over the aorta, noting for any pulsations or masses. So no, I don't feel any masses. I can feel the pulsation of his aorta. I'm just going to go ahead and take a listen. With the diaphragm and with the bell. Now listen over the iliac arteries. The renal arteries. All right, so I don't hear any bruits or anything over the aorta, iliac, or renal arteries. So, sir, I want to just continue to listen to your heart in a couple different positions. I'm going to have you roll on your left side. So I want to listen to the apex of his heart. At the apex, at the mitral point, this is the best place to listen for mitral valve stenosis. So on his left side, I'm just going to take a listen. sound there. It says in the book you're supposed to kind of keep your stethoscope on the spot and then have the patient turn on their side, but I sort of did it out of order, so I'm just trying to find exactly where I was before to hear his heart the best. Okay, good. And then I'm going to have you sit up for me, and one more listen here. I'm going to have you lean forward, and again, I'm going to listen. I'm going to have you take a big deep breath and blow all your air out, and then when you do that, I'm going to listen over your heart. Let me get my stethoscope in the right place. So big deep breath in and out. And this is the best position to listen for aortic regurgitation. Listening on, yeah, great, sorry. Okay, listening at the apex and along the sternal border. So I don't hear any murmurs, gallops, any pericardial friction rubs. His heart rate is regular. The PMI is located at the 5th intercostal space, midclavicular line on the left-hand side. What else? The aorta, iliac, renal arteries, there's no bruits. Carotid arteries, palpated at 2+ bilaterally. No bruits noted, no jugular venous dissension. And that will conclude the cardiovascular and respiratory examination for today.
Part 3.
Part 3.
Part 3.
Thank you. Thank you, patient.
You're welcome. You think if I make your professor laugh with a dumb joke, you'll get a better grade?
I doubt it.
Why didn't the lifeguard try to save the hippie? Give up? Because he was too far out.
Oh my God. Goodbye.